not only for the pediatrician but all the doctors. We have an overview of the chest X-ray. To talk on this, we have Professor Swapon Kumar Roy, who is the professor of Kishanganj Medical College and the scientific chairperson of West Bengal Academy of Pediatrics. Dr. Swapon Kumar Roy is a great academician and a passionate teacher. He has special passion for teaching the chest X-ray and the other X-rays. So I think he will be the best person to talk on this overview of the chest X-ray. Over to you, Professor Swapon Kumar Roy.
Thank you, Professor Sharkar, for your kind introductions. So today we'll be discussing about the very common. Is it visible?
Yes, go to slide show mode here.
So we'll just discuss about the very common day-to-day practice. So interpretation of the chest X-ray in the children's and the neonate. Previously, you have listened to last 2 days about the MRI, CT, and different type of the MRI in sequences and anatomy and all that. But you must know that you should know the interpretation of the chest X-ray because it is the bread and butter of any physicians or any medical personnel. So next 1 hour, I will be talking about interpretations of this chest X-ray. And I'm fortunate enough to share with you the first X-ray done under the sun. It was done on the none other than the wife of Dr. Röntgen, the Anna Bertha Röntgen, in the 22nd November 1895. And when the X-ray was shown to her, she said that I saw my death in my own eyes. So this is the first X-ray on this earth. So before going to the details of the radiology or X-ray of the chest or any other thing, you must have heard that, seen that analog. Analog X-ray are the old X-rays machines that have been used to take a picture, and that has been processed in a film, and that has to be developed and then dried and then sent over the view box. But now things have changed a lot. So what we now do, either we do the computer radiography. It means that analog X-ray machine can be converted to a computer radiography by using a cassette-based phosphorus storage disc, and which is then scanned by a computerized system into a digital format for processing and then printing, obviously. And it takes just a very little time, 5 to 7 minutes. On the other hand, the digital radiography is a very recent one and uses a very flat panel detector based on the direct or indirect conversion of the X-ray to a charge. That is the electrical charge that has been processed by the computer into a digital image, and it is very fast process. But it is expensive, so it is just seen in very few ultra modern setup. This is the computer radiography. What you see is the old one, and this is the computer where you see we can modify the X-rays and then we print it from this console. This is the computer radiography, and digital radiography, there is no need of this machine. You can directly see from the computer and get a printout. So digital radiography is better because it's a comparative study. The computer radiography is still in use because it has got lower investment cost, and particularly if there is any X-ray machine, you can convert into a computer radiography machine. But digital, it is more expensive, but the lower dose than analog in the computer, but in the digital, there's a very low dose of the radiations because we are now concerned about the radiations also. But the image can be digitalized, and here you can even in digital X-ray, you can even put in the cloud. Can you see the cursor? Can you see the cursor?
Yes.
So you can put it even in the cloud, and the image can be viewed in 5 to 7 minutes in the computer, and in digital it is within 1 minute. But they have got some advantage also, as it is less expensive and repairment charge is also very low in case of the computer radiography, but in digital X-ray it is more costly. So depending upon the financial compatibility, you must go either for the computer radiography or the digital radiography. So after you have learned about the CT and MRI, and in the later part you will be also listening to the USG of the brain. But I'm telling you, at least 65 to 70% of the radiological examination, what we do is the chest X-ray. So rest USG is about 10%, CT and MRI almost 5%, and the other are the nuclear and the vascular. So you have to know how to interpret a chest X-ray properly. And because sometimes the importance of the radiology or the chest X-ray is that sometimes the clinical signs and symptoms, in particularly the children's, are not very prominent, and is the very poor predictors of the pulmonary infections. And when you send a backtake or a culture study, it would at least take 5 to 7 days, and by that time either the child may worse or the child will completely recover. So chest radiography might be a best available diagnostic standard any setup, be it a rural or any other setup. So valid indications of the chest radiography. What you do? Why you suspect a severe disease? The child is coughing like anything. The child has got dyspnea, a high fever, swinging temperature. So you must go for a chest X-ray. Or if the confirmations or exclusion of the diagnosis in the presence of atypical presentation. So assessment of the complication. Say a child has developed a lobar pneumonia, and now the child is not improving even after instituting the proper antibiotics. So you must see whether the child has developed empyema as a complication or not. And other causes of respiratory distress, a lot of causes I will discuss when I'll be showing you the neonatal X-rays. There are a lot of other causes of the respiratory distress apart from the pulmonary causes, in the heart cause or the central cause, metabolic cause, and the neurological cause, etc. So you must know how to read the X-ray properly. So views, you must know this is the PA view, AP view, lateral view, and the lateral decubitus view. So these are the views I will discuss in the next slides. So the steps of interpretation, so that you cannot miss anything, are from the outside inward. It means the soft tissues, then bones, domes of diaphragm, then look at the trachea, then cardiac silhouette, superior mediastinum and the hiatus shadows, costophenic sulcus, and at last you must see the lung fields. Don't jump upon to see the lung fields first, or then you will miss something. So what is the difference between the AP view and the chest PA view? It will be required for the PGTs. So look, any child that is in a PICU or the NICU, so he lies in a supine position. So X-ray will be coming from the above, and a cassette or the X-ray plate will be put just below him. So the anterior part of the chest is facing the tube of the X-ray. So it will be AP view. And the PA view, if it stands erect, or if you just suspend the child in a hanging positions, and you keep the X-ray plate or the cassette in front of the chest, frontal part of the chest, and you send a beam from the back, so it is called the PA view. And this is the X-ray chest AP view and the PA view. I will come later about what are the differences, but the main difference is that the heart shadow will be looking enlarged in cases of the AP view. Why? This follow the rule of the optics. So this is the object, this is the light source. Here it is the X-ray tube, and this is the either a curtain or the plate or the cassette. So if the ray goes at the top and the bottommost point, so this is the maximum size of the image we can get, because it is just close to it. So if it is the PA view, so the plate or the cassette will be close to the body or the heart of the patient, so there will be less magnification. Now see, this object goes much more close to the radiation source and much afar from the cassette or the plate. So what will happen if the ray are sent? So see the exaggerated shadow on the X-ray plate. So when the AP view is there, it will be closer to the source, but it is away from the cassette. And that's why the heart being the anterior structure, it will look enlarged in the AP view. Hope this is clear. And there are some differences of the AP and the PA view. PA view, the heart will be well delineated because it is close to the X-ray film or the cassette. Heart will not be magnified. I have explained. The scapula are more widely drawn laterally because we ask the patient to just close hold that particular X-ray plate or the cassette. And in case of the AP view, heart will look larger. Details of the pulmonary area or the anatomy will not be well visualized. The clavicles is always higher in position. If you just look this one, the clavicle will look higher. This is the clavicle in the AP view, and this is the clavicle in the PA view. It will cross the lung pits at the apex. It will cross the apex, but here in the AP view, it will not cross the lung pits. It will be much above. So, but there are some advantage over the AP view. If you want to see the disc space, particularly the cervical or the dorsal, go for a AP view. So these are the things that you must ask the radiographer, what view you want. Most of the time, we need a PA view because you want to see the heart shadow and the lung proper. What is the lateral decubitus film? Because I said AP view, PA view, and the lateral decubitus film. Here, you see a man is turning on a side. And this is the X-ray plate. Can you make out? This is the X-ray plate. And from here, we are sending the beam of the X-ray. So if there is air here in the, this is the left arm. So if the air in the left side, the air will go up. But if there is fluid in the right side, the fluid will scale down. So this is the thing. If it is the air, it will go up in the lateral view. But if it's the fluid, it will scale down over here. So if you want to see any fluid, turn the person to the particular side. Say we have suspecting right-sided pleural effusion. So turn the patient to the right side. But if you want to see air in the right side, turn the patient on the left side, because on the right side the air will just scale up. Here is the air color. And but sometimes when you see the X-ray, you also see the abdomen, you also see the soft tissues and the bones. So before coming to the chest proper, try to see anything abnormal in the visualized X-ray, the abdomen, anything, any calcifications or any air you must see. And the bone. Bone is very important because if you do not concentrate, you may miss a lot of things. And you must know whenever you are getting an X-ray, whether it is of good quality or not. If you just see on the left side, this is the same picture that has been taken, and this is the next picture. So see which one is better. This one is better, definitely, because of the clarity. So as in the photograph, we need clarity. We also need clarity or adequacy in case of the chest X-ray. Now you can compare. This is the same X-ray of a same child taken at the same time. But look at this. Is it okay? Naturally, your eye will tell no. The right one is proper. But there are some factors by which you are telling this. So in frontal film, this is the frontal film. This is the lateral view. You must see the cardiac silhouette. This is the cardiac shadow, and within it, you must see the pedicles of the vertebra. And the bronchovascular marking should be well visualized within the cardiac silhouette. On the lateral view, this is the cranial side, this is the caudal side. The cranial vertebral body will look much more whiter or opaque than the caudal one. The caudal one will look darker or radiolucent. So this is the magnified view. This is the cardiac silhouette, and you can see the vertebral bodies. It will not be so well seen, just like the AP view. So these are the bronchovascular marking, and I'm showing you this is the lateral view, and you can see More caudal one, it will look darker or radiolucent, and this is the opaquer. So it means particularly this frontal or lateral view is okay. And what are the other conditions of the adequacy of a scagdom? One must be able to count down 10 posterior and 6 anterior ribs. Forget about the 10 posterior. Just try to see 6 anterior ribs. You have to count. So the three main factors that determine the technical quality of a radiographs are: number one, inspiratory film or not, whether it is been adequately exposed or not, it means the penetration of the X-ray is adequate or not, or there is any rotation or not. So try to understand. In the inspiratory film, we always want the inspiratory film unless there is some exception. And how do you know it is the inspiratory film? Just look at the X-ray and see in the anterior ends of the which rib cuts the right dome of diaphragm, because left side there is a heart and there would be problem. So it is convention that we look at the right side and see anterior ends of the which rib cuts the right dome of diaphragm. Usually the anterior ends that cuts the right dome of diaphragm are 5th or 6th. But if it is 4th or 3rd, it means it is the expiratory. If it is 7th or 8th, it will be the overinflations. We don't never call it as the emphysema, because emphysema is a pathological term and it is irreversible. But in the children, the most of these overinflation are reversible. And this is the example. This is the inspiratory film. You can see it. So this is the end of the first rib, 1st, 2nd, 3rd, 4th, 5th, and 6th. So 5th and 6th it has cut. So this is the inspiratory film. Here is the expiratory film. Here is the 1st, 2nd, 3rd, 4th, 5th, 6th, almost 7th. So this is a mild expiratory, not 5th. Yeah. This is the 1st, 2nd, 3rd, 4th, 5th. So it is a mildly expired film, but you should see what you are making out. Sometimes the expeditions is required to look out any small pneumonia. So it is a small consolidation. You are clinically, you are listening to some crackles. There is fever, there is cough, and the X-ray reveals this one by inspiration, but your clinical suspect the child might be suffering from pneumonia. Ask the radiographer to get a expiratory film, because it can pick up a small pneumonia. And to see a small foreign body, sometimes we ask the radiographer expiratory film, because otherwise you can miss it. So penetrations, whether it is overexposed or underexposed. I have already told you that within the cardiac sylvae, we must see the thoracic vertebra and the pedicles, and you can see the bronchovascular marking. In underexposed film, the less number of the X-rays are traversing through the cardiac sylvae to the back. So what will happen? The lungs will appear much more denser or opaquer, and it may just confuse that there must be some infiltrates, and you can consider it as a pneumonia. So this is the X-ray. You cannot make out any vertebral bodies, neither there is any bronchovascular marking. So, and whole lung fields appear much more whiter or opaquer. So this is the less exposed, underexposed. And this is the overexposed, actually the reverse. More amount of the radiations or the X-ray are penetrating through the lung parenchyma. So lung parenchyma will look like this one. So darker, even the heart may look darker. But sometimes to see the miliary mottling or small pneumothorax, the overexposed film is required. So if you suspect that the child might be suffering from the miliary tuberculosis or the miliary cirrhosis due to any other cause like the pneumoconiosis or other, so you must go for a overexposed film. And rotation. How do you determine the rotation? This is the middle part of the clavicle on the both side, and this is the spinous process. So on the either side, it should be equidistant. To the medial end of the clavicle of the left side and the medial end of the clavicle on the right side, it should be equidistant from the spinous process. If anything gets closer, so it means it has been rotated to that particular side. So what are the silhouette signs? Sometimes we come across the term the silhouette sign. Silhouette sign are nothing but some radiopaque shadows that causes obscurations or that obscure some of the cardiac borders, some of the borders of any of the organs within the thoracic cavity. Say there is a radiopaque shadow over here on the left cardiac border at the near the apex. So it must be a lingular segment involvement on the of the left upper lobe. So left heart border is being obscured by the lingular pneumonia in the lingular segment, and this shadow then called is the Silhouette sign. And the hemidiaphragm, say this one, we are not seeing the hemidiaphragm on the right side. So there must be a right lower lobe lung disease. Same like that. This is the paratracheal one. This is the paratracheal, and the chest wall in the left lung or blood disease we can also get over here. So the Silhouette sign are nothing but it refers to loss of normal border between the thoracic structure. It is usually caused by the intrathoracic radiopaque mass or lesion that touches the border of the heart or aorta. So this is the Silhouette sign. Now we have gone through details within the last 15 to 20 minutes about the basics how to read the chest X-ray. You have to go, I'm telling it repeatedly, you have to go in a structural method. You cannot skip anything. You should see from the outside inward soft tissue, bone, the diaphragm, the trachea, the cardiac silhouette, superior mediastinum, and the hilus shadows, then the postoperating sulcus, at last the lung fields. And be consistent with the method. So there, please don't take any shortcuts and don't look at the reports of the radiographer. You try to look all the X-rays yourself and interpret, then at last you see the report. So next, I will just request all of you, when I will show you the X-rays, when I will tell in your chat box, within 5 seconds, you just write it. If it is not 5 seconds, maximum 10 seconds can be given, because it cannot be a one-way teaching. You must interact with that. That's why I can know that you have imbibed what I was trying to impress upon you. So this is the first X-ray. So you start giving answer. What can be these diseases? Arundhati, you were seeing possibly. So see the whether they are answering or not. No answer?
No answer till now.
So I told you that you must see from outside inward. So see from outside inward. So these are soft tissues. What you were seeing, there are multiple radiolucent shadows over here in the neck, in the axilla, and all that. So, and there is nothing abnormal in the lung fields or something like that. Some abnormalities over here. So this is a case of air within the soft tissue. So what it can be? It is the surgical emphysema. Believe me, this was the child in Institute of Childhood, and mostly all maximum X-rays were taken from the Institute of Childhood, and I must acknowledge the contribution of the Institute of Childhood Radiology Department for this. So these are the surgical emphysema, and I could find the
We got two correct answers.
And even to the hands. Yeah, we can palpate. We can palpate the crepitus over there. So, have they given any answer?
Yes, we got few correct answers.
Very good. Congratulations. Congratulations. It means at least two have understood. So, what is this? Again, you just write down the answer within 10 seconds. So I got two answers. What are the answers?
Empyema, hyaline membrane disease.
Hyaline membrane disease. So
Light pneumothorax.
Okay, right pneumothorax. Someone has said right pneumothorax is very good guess, but actually, if you follow, he has seen. Just look, I told you that you must see the soft tissues. Here, in the soft tissues, we cannot see anything. But if you follow the anterior axillary line, this is the anterior axillary fold. It is very heavy. And that's why it has camouflaged you to the diagnosis of right-sided pneumothorax. So this is a heavy anterior axillary fold. Anterior axillary fold naturally is a soft tissue. So be cautious enough in interpreting. Try to see the child first. What is this X-ray? Now this is the X-ray where you can see the lateral half of the clavicles are not visible. You can see, and the clavicle looks very rudimentary, and there is a chaotic these ribs configuration. So it is a thoracic dystrophy with some rudimentary clavicle. So those who have seen the film of Pa, so this is the X-ray of the Ekramul who was suffering from progeria or Harrison-Gilford disease. So this is the progeria, the clavicles of the progeria. In fact, the patient came to Institute of Child Health. I was lucky enough, I was at that time in Institute of Child Health. So I could see this X-ray and it came to me only for the X-ray. So what is this? Again, you try to see, I'm giving you a hint. Try to see the bones now. So your time starts now. Any answer, Mihir?
Absent clavicle, one answer.
Very good. Many of getting the absent clavicle. So it is the right answer, the absent clavicle on either side. That clavicle was rudimentary. It was rudimentary, visible but rudimentary. Here it is totally absent. So this is a child of cleidocranial dysostosis. So whenever there is total absence, it is whether cleidocranial dysostosis, it is a absent or some rudimentary clavicle thing of the progeria. Obviously, you should see the face and other things also. What is this? Your time starts now. Any answer?
Clavicle rib. Cervical rib. Cervical rib.
Yes. So this is also a correct answer, possibly. What is this? Again, come to the bones. Cervical ribs, very good answer, because I cannot see the upper part of the X-ray. So this is the cervical rib. And what is this? Look at the right side and look at the left side. This is the left, this is the right. Yes, somebody has answered. So if you look carefully, these are the thickening of the ribs, and there are multi-layered ribs. You can see the multi-layered ribs. You can see 1, 2, 3, 4, 5, 6 layer ribs. So it is the case of infantile cortical hyperostosis or the CAFE's disease. So CAFE's disease is the costal involvement of the CAFE's disease. You usually see the mandibular involvement of the CAFE's disease, and here I am showing you the costal involvement of the CAFE's disease. CAFE's disease may occur at anywhere in the, except the phalanges and the vertebral bodies. So I have shown you the and there is some amount of very fine paraneumonic effusions also because of the inflammations of the adjacent pleura. So your eye should be just like that. You cannot miss anything over here. No, sorry. Now I can see it. Now, what is the answer? Now, what is the answer? So your time starts now. Again in bones. I cannot see the upper part of my presentation because of the panel is obscuring my view. Okay, but here I got because somebody has answered wrong in the previous one. You can you see this one? This one is the cervical rib. This one is the cervical rib on the right side. Okay, this one. And the previous one, what you have given the perfectly normal X-ray. Most difficult X-ray that you can interpret is the normal chest X-ray. And here is the cervical rib. Here is the cervical rib. What is this? Again, there is the chaotic configurations of the these ribs. Some are very thin, some are slender, some are wider, some are missing over here. This is the thoracic dystrophy. Here in this X-ray, you can see the cardiac silhouette is enlarged, and there are some underminerations of the visualized vertebra. So it must be a case of chronic hemolytic anemia, and this anemia has produced the enlarged heart shadow. So most probably this is a child of chronic hemolytic anemia. And here you see the ribs. Ribs are falling short of the sternum. So it is a short rib. So it is seen in case of achondroplasia. You can see in case of asphyxiating thoracic dystrophy. You can see even in case of Ellis Van Creveld syndrome. So this is the AP view of the child. Another child, you can see the ribs are falling short of the sternum, and the anterior ends of the ribs are a bit wider. So it is a case of achondroplasia. Here, look at the bony thorax. Now, again, the anterior ends are just like a dumbbell set, and the ribs are very much sclerosed. So, and the cardiac silhouette is enlarged. So, this is a case of osteopetrosis or marble bone disease, as it is the sclerosed bone marrow is being replaced by the sclerosed bone. So, there will be less amount of the marrow to form the blood, and the child usually suffers from anemia, and that's why the cardiac silhouette gets enlarged. So this is a osteopetrosis or marble bone disease. Again, bones. If you look carefully, anterior ends of the ribs are much more wider. So, and the child came with the obtunded positions. On inquiry, we came to know that this child's father was producing the large batteries, and the battery contains lead, and the child started by 9 months the child started crawling, and he used to chew all these batteries that left over, and it was a case of lead poisoning, or you can say it's a heavy metal poisoning. So anterior ends become much more sclerosed and white. And it was being diagnosed by one of my Professor Jayanto Bose, and he said the child might be suffering from lead poisoning. So get lead done, and it was, came positive. So we have finished the bones. Now we will concentrate on trachea. Can you make out anything? Answer within 10 seconds. Otherwise, I will not be able to finish the whole presentation. Be first. Anything abnormal? No.
One
So,
answer, triple sign.
Somebody
Triple sign, they have answered.
not triple sign. Yes, here is a very good answer although. So this is, if you look carefully, this is the rat tail sign. This is the rat tail. So the distal part has become the Qingtao, and there must be something that is spacing. So paratracheal lymphadenopathy in ALL may sometimes produce a pressure effect over the trachea, and this is called rat tail sign. So these are the tracheal stenosis or the tracheal compressions. So why I am showing you? Because you cannot miss it. Because you can tell the physicians that there is something abnormal. You must look into the particular child clinically, and it was revealed it was a case of ALL. Now going to diaphragm, because I said after trachea, try to see the diaphragm, because then we will, the soft tissues, the bones, the trachea, then we will encircle the thorax from the abdomen. So we must see the diaphragm. So here in the left side, you can see the diaphragm has gone up. So what it is? So very first answer, I think. So Mir, what is the answer? Because I cannot see the answers.
Yes, congenital diaphragmatic hernia, eventation. These are the answers.
Okay. So this is eventations I may take, but this is not a congenital diaphragmatic hernia because there is mediastinal shift. There's a very smooth outline of the left hemidiaphragm, and this is the fundal gas shadow. But I must sensitize you about the diagnosis of the diaphragmatic palsy or diaphragmatic weakness and the eventations. So in case of diaphragmatic palsy, the whole diaphragm get involved, whole hemidiaphragm or bilateral also. But in case of eventation, only a part of the diaphragm gets affected, not the whole. So this is the picture. You must be familiar with this. On the right dome of diaphragm, the medial side is much more convex upward, so tinting like that. But there is no pneumonia, so it is not due to the basal pneumonia. So it is the anteromedial musculature weakness of the right dome of diaphragm. The rest of the diaphragm musculature remains normal, and it is mainly due to the failure of migrations of the myotones. And here it is the eventation. So this is called partial eventation. So this is the partial eventations of the right hemidiaphragm. We call it the anteromedial musculature weakness of the right hemidiaphragm. Here you can see there is looks like the split diaphragm. You can see the split diaphragm. Again, the anterior part of the diaphragm musculature is affected, not the whole. So this is the main difference. The diaphragmatic eventations from the diaphragmatic paralysis or diaphragmatic weakness is that in eventation, only a part of the diaphragm is involved. In diaphragmatic palsy, the whole diaphragm is got involved. And if the bilateral diaphragmatic eventation is there, the Warding-Hoffmann disease and some congenital infection like the toxoplasma, that should be considered. But unilateral hemidiaphragm can be seen in the trisomies and even in the other Beckwith-Whitman syndromes, something like that. So this is a partial eventation. Now we are coming more closely to the claustrophrenic sulcus. So answer very fast. What abnormality you were seeing here? Any answer? Be very fast, otherwise I will not be able to finish.
No answer till now.
So if you look carefully on the left side, there is a denser shadow. It means an opaque shadow, and there we cannot see any bronchovascular marking over there. But here, the difference between that heavy anterior axillary fold and here, we can see the collapsed lung marking. So it is a left-sided pneumothorax. So this is the left-sided pneumothorax, and this is the collapsed lung margin. So I think you must got bored about listening so much of the pulmonary pathology and the boundaries. So let me go to the cardiac X-rays also. Already you know what are the boundaries from. This is the by the right atrium, because right ventricle never forms the boundary of a heart. It remains here only. The 2 is the right ventricle, and from here this is the superior vena cava, and this is by the right atrium. Here there is the aortic knuckle, then pulmonary chorus, and the left ventricle. So these are the demarcation you must know, and if you are lucky enough with a good X-ray film, you can see the inferior vena cava. So, but mostly we consider the superior vena cava, right atrium. Right ventricle never form boundary of any heart border. So I told you in the previous X-ray that the child might be suffering from the cardiomegaly. So how do you see the cardiomegaly? Just draw a perpendicular line through the spinous process, go maximum diameter to the right, and go maximum diameter to the left. And if you join this, say this is the O, this is the A, this is the B. So AO and OB line is the cardiac diameter. And go maximum transthoracic diameter. My teaching was that go from the topmost part of the right dome of diaphragm, and this transverse diameter is called the thoracic diameter. But nowadays people are just changing it. They are taking possibly this maximum transthoracic diameter up to infancy. It means up to 1 year of age. The normal cardiac diameter is 0.6. It means 60% of the thoracic diameter is the cardiac diameter. And beyond infancy, if it is more than 50% of the thoracic diameter, we call it cardiomegaly. And possibly you have seen it in the previous thing. It's just a recapitulation of the thing, because in the ECG and the echocardiography, we have already shown you this exercise. I'm going first. This is the right apex of the heart is on the right side, and you can see the fundal gas. So this is the dextrocardia with situs inversus. And this is a huge cardiomegaly. Now you know how to see the cardiomegaly, but look, the cardiac contour has been maintained. So you must go for an echo, and echo will reveal there is pericardial effusion. So if the cardiac contour is maintained with a huge cardiomegaly, go for pericardial effusion, and this one will be narrow. The heart pedicle will be narrow. Here also, this is a huge cardiomegaly. The pedicle is not so narrow, but the cardiac configuration is not. So it is a hypertrophic cardiomyopathy. Here on the left side, you can see a bulge over there. So it must be a pulmonary hypertension. On the right side, you can see much of the pulmonary plethora. So this is the pulmonary conus bulge, and this is the right side. You can see lot of vascularities over there. So this must be a case of pulmonary hypertension. Here, this is again enlarged heart with multiple. This is the pulmonary plethora, and there may be some pneumonia over here and the right lower zone. So this is a case of ventricular septal defect with Eisenmenger complex with pneumonia. Here, I'm showing you because you have seen the boot-shaped heart. Here is a boot-shaped heart, but I can see the atretic pulmonary artery. So if there are features of tetralogy of Fallot, but you are missing something like one component, we call it Fallot's physiology. So here the atretic pulmonary artery is not visible, others are present, and it looks like a boot-shaped heart. So this is the Fallot's physiology. Here you see the oligomic lung fields. The vascularity on both the lung fields are low. And here the pedicle is very narrow, as if it is suspended by a string, and it looks like an egg. I am not very much imaginative. So it is an egg on a table seen in case of transposition of the gate arteries with diminished pulmonary blood flow. So TGA may be with the increased pulmonary blood flow. TGA may be with decreased pulmonary blood flow. Here, what we are seeing is a TGA with decreased pulmonary blood flow. That time I am showing you this X-ray because this X-ray will teach you many things. If you look carefully, the whole lung appears hazy. And if you look carefully, there are some straight line that is coming from the apex to the hilar. So we call it Carlis A line. If you go to the right side, there are few transverse line. I don't know whether you can be able to see that. You can see a perpendicular line, perpendicular to the this line. So these are seen in the bases. So we call it the Carlis B line. And there are some fluffy viscous opacity at the central part. We call Carlis C line. So Carlis A for apex, Carlis B for the base, and Carlis C for the central or the viscous. So this is a case of pulmonary edema. Another pulmonary edema can be seen where you can see there is some smudged appearance on the both sides of the lower lung fields. So this is also called bat wing sign. Here, if you carefully look at this right part of the heart, there is a cell-like projection. So it is the right lobe of the thymus is enlarged. So you cannot diagnose this child to be suffering from a pneumonia. And there is a pear-shaped shadow and looks like the thymocardiac shadow is enlarged. This is another presentations of the thymic enlargement. Here in the left border, you can just see the notch. This is the notch. This is the notch. Left border, if you just follow it, there is a notch over here. So if the left lobe of the thymus is enlarged, we get the notch sign. But here, the left border of the heart looks wavy. This is the another presentations of the thymic enlargement. So I have shown you different type of thymic enlargement. One is the cell sign. Another one is the notch sign. There is the enlarged thymocardiac shadow, and there's maybe wavy left border of the heart. So sometimes you might be seen and you must be astonished. What was the diagnosis? It is nothing but an enlarged left lobe of thymus. Now look at the parenchyma. I told you at last you look at the parenchyma. If you look at the parenchyma, you can see a calcific shadows over there. So any pulmonary lesion in the children, they get calcified. But in the adult, you have seen in case of corona, there was fibrosis. So this is a calcified primary complex. And if you, there is a draining lymphatics and this is the hilar. So the calcified primary complex. I won't go details of this thing because airway pneumonia now it has replaced the bronchopneumonia. Airspace pneumonia has replaced the term lobar pneumonia, and interstitial pneumonia. You know very well that we can get the interlobar septal thickening, nodular shadow, and the reticular defined linear shadows. Airspace pneumonia. What you know about this lobar pneumonia are the airspace pneumonia, and one peculiar finding is that periphery will be smudged and centrally you can get the air bronchogram. I am showing you the X-rays. So, but you must know which lobe gets affected. You must know which are the lobes on the right side. So take from the T2 vertebra, draw a line to the anterior ends of the sixth rib, and this denotes the major fissure. And from that, from the fourth, if you just draw a horizontal line, so this is called the minor fissure. This zone is the zone where the middle lobe remains, and this is the right lower lobe. And above this minor fissure and the part of the major fissure is the right upper lobe. Same here in the left side, from T2 vertebra to the anterior end of the sixth ribs. So anterior end T2 vertebra to the anterior end of the sixth rib. The part above is the left upper lobe, and the part below is the left lower lobe. So with this, again, this is the airspace pneumonia, lobar pneumonia. See, the radio opacities are much more concentrated on medially, but if you just follow on the lateral side, it is getting smudged unless and until it touches the pleura or it touches a fissure. And in the medial side, I don't know whether you were appreciating or not, there are some ear shadows over there. We call the ear bronchogram. So this is a case of lobar pneumonia or airspace pneumonia, left upper lobe and the right upper lobe. Here, I have told you, again, you see the right cardiac border, lower half the right cardiac border has been obscured. So this denotes the right middle lobe. We call it Brooks pneumonia. Brooks pneumonia peculiarity is that the pathology of what you were seeing there is in the pulmonary area, but it must be, there must be anything compressing all the lobe that is supplying the right middle lobe. So pathology is somewhere and you are getting a radiological picture somewhere. So this is the Brooks middle lobe pneumonia. And it is also a features of the Selway sign. So this is the right middle lobe pneumonia. You can well appreciate over that. So what is this? Again, lobar pneumonia, but here we can get a very beautiful finding, radiolucent thing, pocket. So this is a case of pneumatocysts. So pneumatocysts, if you see, it is generally seen in cases of the Staphylococcus aureus, Streptococcus, E. coli, tuberculosis, something like that. But here the lower border is sagging. This is the classical radiological picture of a Klebsiella and pneumonia. If you look carefully, your eye must be ready. There is some denser shadows behind the cardiac silhouette. This is the left border, and this is the denser shadow. So retrocardiac pneumonia you cannot miss. If you see some of the very demarcation zone over here, you must get a lateral view done, or you can go for a chest MRI or CT MRI, CT chest. So this dense radiopaque shadow looks like a rounded shadow. This is the round pneumonia. It's seen mainly the child below 7 years. After 7 years, the pores of cones and the channels of numbers, they are well formed, and before that it is not well formed. So it is the nature's gifts to the child to circumscribe any pathological lesion. Well, after the pores of cones and the channels of the numbers are formed, they can spread to the other lobes very fast. So this is called the round pneumonia. I have told you that some of the varieties of the interstitial pneumonia. So interstitial pneumonia, that you can see the septal thickening and the linear marking even up to the periphery. If you just draw lateral, this is the middle, and this is the medial. So it will, in case of hyperreactive airway disorder, you can see at the medial lung fields. So this is the medial lung fields, but if you can follow to the lateral, even at the periphery. So this is a case of interstitial pneumonia. So it happens of the post-measles bronchopneumonia. Nowadays, we have seen a lot of post-measles pneumonia, interstitial pneumonia. This is the X-ray that you can see there are multiple air fluid level on the left side. So this is the multi-loculated lung abscess. Here, the lateral view you can well see 1, 2, and 3. There is a very well circumscribed round radiopaque shadows over there. If there is very well circumscribed, always think it must be a SOL. What was this case? We have revealed it is a case of hydatid cyst. Again, the difference between these two, you can make out the total border, but here you cannot make out the total border. So it must be a loculated pleural effusion. The cardiac silhouette, the mediastinum is shifted to the contralateral side, but it has not followed the Ellis S-shaped curve. What is the Ellis S-shaped curve? The apex will be narrower in comparison to the base. I'm showing the picture. So this is the Ellis S-shaped curve. So the upper part is much narrower than the broader lower part, and the costophrenic sulcus and the diaphragm is obscure, but it is not seen in case of this. So this is the must be a pleural effusion of the empyema or the right side. The left-sided pleural effusion on the empyema. So this is follows the Ellis S-shaped curve. So there are multiple small lucencies over here. So we call it miliary mottling. So miliary mottling doesn't mean that the child is suffering from miliary tuberculosis. Lot of causes, the pneumoconiosis, mitral stenosis, blah, 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 that can produce the miliary shadows. Here also it is the miliary shadows. It was our child of Howrah, and we have seen the child was suffering from medullary carcinoma thyroid. These are the metastases. So here there are multiple small shadows, and there are some radiolucencies over here. So this is the pulmonary alveolar microlithosis. This is the case of congenital tuberculosis. All are miliary mottling. Here also the miliary mottling. Miliary mottling may be from the size of a millet to almost over 1 to 2 centimeter, but all are miliaries. You must know this is a very interesting case. This is the aspiration of the hypersensitivity pneumonia. The mother has forcibly given the child the pulse or dull. So what happened? It has entered into the lung through the trachea, and it has caused some hypersensitivity pneumonitis. This child has came to our institute from the other institute with this picture, and the child presented with the nystagmus and the opsoclonus. And there was weakness on the both lower limbs. So this was a very rounded shadow, and I'm told when you see the rounded shadow, and this is situated in the posterior mediastinum, so it must be a case of SOL. So it was a case of neuroblastoma. Here, some sticky opacities over there, the adolescent girl. So we are thinking what it can be, and the child was losing weight. So we did an MRI, and MRI saw multiple miliary shadows over there. So MRI can definitely pick up miliary mottling. Here, there is radio opaque shadows over here on the right side. So this is the pulmonary sequestration. So pulmonary sequestration, what is the peculiarity? It is not getting the blood supply from the other part of the lung. So it is getting supply from the abdominal systemic vascular supply. So, and it is dysplastic and non-functional. The pulmonary sequestration, that lobe has to be get rid of. We must operate that lobe. Here we have shown on the left side. On the right side, left side, there is radio opaque shadows. On all that radio opaque shadows are not pneumonia. So we have done this, and it came out to be a case of the duplication cyst. Another radio opaque shadow. So we are confused. They have given also the antibiotic. The 2 years male child. We have done a CT, and it ultimately revealed it's an anterior mediastinal opacity, and it got a diagnosis of the bronchogenic cyst. So I have shown you the bronchogenic cyst. I have shown you this duplication cyst, and I have shown you also the pulmonary sequestration. So try to diagnose these things whenever you see something radio opacities in the lung fields. This is a very interesting case. This child has presented with this rusty sputum and the anemia. There was almost a homogeneous opacity in filters. So we have done this lung function and showed hemosiderin-laden macrophage. So very rapidly, I will go, if I get 10 minutes of the question answer, because I have taken the questions, so I can finish this new one. Mostly the newborn exercises are done for the respiratory distress and the congenital anomalies. So these are the chest exercises. You must know what is the anatomical and the physiological differences. Because from the womb and the fetal to the neonatal life, there is a transition. Some transitions are very slow, and sometimes what you think abnormal may be a normal finding. You must know some anatomical landmarks and some congenital defects. And most of the time we have got a confidence that I know everything. I have told you that I will tell you the respiratory distress might be case of the systemic disease like the septicemia. They may present with the respiratory distress. And any extrathoracic cause like the CNS, hemorrhage within the brain, or any neuromuscular condition, the skeletal abnormality like the achondroplasia, any abdominal, the huge abdominal accumulation of the Milroy disease, you can get it. And intrathoracic, the surgical causes, the medical causes. Medical causes, the three conditions you must know. One is the this transient tachypnea of newborn, hyaline membrane disease, meconium aspiration syndrome. And surgical causes, diaphragmatic hernia, the congenital lower overinflations, or diaphragmatic hernia, and all that. So I am coming one by one. So this is the thing we see a lot of infiltrates over here. And it was a transition zone. So you just wait and see for the 24 to 48 hours. It might be a case of transient tachypnea of the newborn. This I have shown you a typical X-ray picture of the older child, and this is the typical X-ray picture of a neonate. Ribs will look horizontal. Ribs will look horizontal, not the bucket handle like. So this is the normal predispositions of the ribs in a case of the normal neonatal X-ray. And here, some of the times we can see in the NICU, and the child got ventilated. This is the ET tube, and you must note where the ET tube should be. Ideally, it's below the clavicle, and it has gone almost into the right lobe. So it has done then iatrogenic atelectasis of the right upper lobe. You must be very careful. So I'm not going into the details. Possibly you all are aware of the thing, but sometimes the baby was not improving, and we have seen the ET tube was in the esophagus, because trachea is the anterior structure, esophagus is the posterior structure, and these two tubes may contain air. So be very careful. Nowadays we use the ultrasound for detections of the tip of the endotracheal tube. And this is another example. It has also gone much down. Be very careful. You must know what is the umbilical artery position and the umbilical venous position. So usually The left one is the artery, the right one is the venous, and there is a dip. Usually we see a dip, but here the funny thing is that it is, though it is a left umbilical venous catheter, there was a dip. So sometimes you cannot say it is a total copybook teaching. It has gone just like the umbilical artery, but it has gone into the inferior vena cava and then into the hepatic vein. So I have told you, by seeing the lung volume, you can diagnose whether the child is suffering from this TTN meconium aspirations or hyaline membrane disease or not. If it is increased lung volume, just take it as a meconium aspiration. If it is the normal lung volume, you can take it as a TTN. If it is the low lung volume, take it as hyaline membrane disease. I'm made much more simplified. Already you have seen this is the central fanning from the hilum, and you can see the obliterations of the these osteophenic sulcus by effusions. You can see the visible this transverse fissure. So fanning from the hilum, the visible transverse fissure, the pleural effusion are the hallmark, radiological hallmark of a transient tachypnea of the newborn, and there may be marginal increase in the volume of the lung. So this is the X-ray that you have seen. This is the absence of the clavicle. You have diagnosed this is the cleidocranial dysostosis, and here you can see the Ormian bones. So Ormian bones are seen in many conditions. I'm not going into the details, but cleidocranial dysostosis is one of them. So this is the picture I'm sharing you. This is the picture of cleidocranial dysostosis. Here already I have shown this is the achondroplasia. These are the conditions where the child may present with the respiratory distress. Just take a lateral, you can see the ribs are not reaching to the sternum, and the anterior ends of the ribs are very widened, and gradually it looks like a spatula shape. Here in the pelvis, you can see a very narrow sacrosciatic notch. This is the sacrosciatic notch, and gradually the other pictures will be much more florid. So this is the thymus. I'm not going into details. This is the pneumothorax on the left side. This is the pneumothorax on the right side. If it is a tension pneumothorax, just we have to put a needle over the second space. These are the multiple radiolucent shadows on the left hemithorax, and it has displaced the mediastinum to the contralateral side. So this is the congenital diaphragmatic hernia. So before sending to the pediatric surgeon, just treat the child with the sildenafil to allay the pulmonary hypertension. This is another X-ray. We can see multiple airfield level, but if you look carefully, this is the triangular shadows over there. So there is a gap in anterior part. So you know there are three types of congenital diaphragmatic hernia. One is the Morgagni, and the Bok-Dalek, and the central tendinous defects. This is the anterior. We call it the Morgagni hernia. These are the child has presented with grunting and respiratory distress. This is the radiolucent shadows on the left side. So we have done a CT and we are seeing the multiple radiolucent cystic lesions. So it is a case of congenital pulmonary airway malformation. Mostly we get a single or multiple large cyst. If it becomes solidified, stage 3, these are solid, and most important is that type 2 are much more malignant. So multiple small cysts, if you see, just to get rid of that, you have to do the lobectomy, because that can turn into a malignancy. So this is another, you can see some radio opacities over there. Lung fields look hyperinflated, and the upper part of the lung, the apex has enclosed even in the mediastinum. This is a better magnified view. So this is a congenital lower overinflation, or you don't call it now congenital emphysema. So lower emphysema, we call it congenital lower overinflation. This is the another thing. So we thought in the first day when the baby was born with the grunting and the respiratory distress, there's opacification. So naturally we thought the child must be suffering from any pneumonia or the aspiration or something has happened. So we waited on the next day. After 24 hours, it is being replaced by this air. So initially, it was not air-filled, and on the next day it becomes air-filled. So it is the congenital lung cyst. So congenital lower over inflations sometimes we see. I am lucky enough to show you a congenital empyema. So this is the empyema. So possibly some immunodeficiency was there. We have drained the pus, and after draining the pus, the child has improved. So empyema is not only seen in the children, it can be seen in the neonates also. Here, the lungs are hypoplastic. So if there is loss of volume of the lung, so another one is that hyaline membrane disease. Other is, this is the case of hypoplastic lung on the right side. This is a classical picture of hyaline membrane disease. You can see reticulogranular, the first phase, then it try to coalesce, and third, it is a white out lung, and you can make out the air bronchogram. So first, second, and the third stage, and you see the lung volume has decreased. This is the typical picture of hyaline membrane disease. So you can appreciate the air bronchogram here. This is the air bronchogram, and there's the totally white out lung. And this is the most iatrogenic. When you give some barotrauma, the earliest radiological feature are pulmonary PIE, pulmonary interstitial emphysema. If you go on continuing with this barotrauma, what will happen? This will coalesce and form these cystic lesions. So be very careful when you give much more pressure. And this child was subjected on the 4th day for meconium aspiration syndrome. It looks like whole lung, right lung was involved, might be left lung also, but the right lung is visible. So the baby was put on 16 days with this ventilator, and this is the feature. So bronchopulmonary dysplasia. Oxygen is also a medicine, so it can cause a lot of injury, not only the ROP, but the bronchopulmonary dysplasia. This is the X-ray done on the day 1. There is a multiple patchy opacities on the right side, but giving an antibiotic after 3rd day is clear. So group A streptococcal infection is also prevalent in our countries also. So try to give 3rd generation cephalosporin, it will improve. And thank you very much. Mihir, I have crossed just 6 minutes, but 4 minutes have been left for the question answer.
Yes, thank you, Sapunda. This was a mesmerizing presentation. You have covered, I think, every possible chest X-ray, and will describe all the normal findings, how to read it, the systematic way to look at that during the session. One question is that, am I audible?
Yes, yes.
Yes. One question is that, so please explain the minor fissure landmark on lateral chest X-ray in the right lung.
This one. This minor fissure, if you just draw a horizontal line at the side of the 4th vertebra. This 4th vertebra is the point from the spinous fossa of 4th vertebra. Then you draw. So this line denotes the minor fissure. It means the fissure between the upper lobe and the lower lobe. If you have got a clear idea, then put in the chat box whether you have understood or not. So this is from the T2 vertebral spine to the anterior end of the 6th rib, and from the 4th vertebra we'll draw a horizontal line, and this denotes the minor fissure. Have you got your answer? Try to see whether he got the answer or not. Am I clear? So should I stop? So you can write
So
down.
one question is that, sir, can you just explain the diaphragmatic palsy again?
Diaphragmatic palsy. In case of diaphragmatic palsy, if the whole diaphragm gets involved, it is diaphragmatic palsy or weakness. But if part of the diaphragm is involved due to a part of weakness of the musculature, we call it diaphragmatic eventations. So we should have the whole diaphragm is involved. It has gone much above. So it must be a diaphragmatic palsy. But look at this. These are the convex or the tinting of a part medial anteromedial part of the diaphragm. So it is the anteromedial musculature weakness. So it is called a diaphragmatic eventations. And here some another it looks like a fit type of diaphragm. So it is the anterior part of the diaphragm that is involved. So if it involves the whole diaphragm, we call it paralysis. If part of the diaphragm is involved, we call it the diaphragmatic eventation. In eventation, whole diaphragm is never involved.
Thank you. And the last question for you is the demarcation of the lobes in the PA view. Is there how can they demarcate?
Demarcations, definitely right side, right paracardiac is the thing. And again, from the fourth, if you just draw a line above the fourth, this is the right upper lobe, and below is the waist segment is the left lower, right lower lobe. And here on the fourth, you have seen because the horizontal line you have drawn. So this is the T2 to 6th rib. So this is the 6th rib. This part is the upper lobe, and this part is the posterior lobe. And there is, I am not going into the nitty-gritties, that you can draw a Y line, and there you can see the segments. The upper one is the apical segment, it's the medial segment, lateral segment. Just make a Y on the upper. There's the medial, this is the lateral, this is the apical. So by this we can do that. And the lateral view, this is the right paracardiac region, denotes the right middle lobe, and there has got the lateral and the medial segment. So segment, it will be very nitty-gritty and very time consuming. So we have skipped that. That should be a totally different aspect. So it will take much more time.
Thank you so much. Yeah, thank you so much. I think now we can move. I think there are one question in the QA box. Suppose that you can just answer there, the QA box, and we can to the next session. Pradeep, are you there?
Yes, sir.
Yes, so you can just introduce Dr. Sogoto Chaudhary and start the session.
Okay. Thank you, Sapun sir, for your excellent presentation. I think you have covered most of the chest X-ray field and also the cardiac CLRT. Our next speaker is Dr. Sogoto Chaudhary. He has completed his DM in neonatology from our IPGMR SSKM Hospital, and he is now posted as the assistant professor in SSKM only in neonatology department. His topic will be cranial USG. Sogoto sir, I will.
Thank you, Pradeep. So today, good evening, everyone. So if just I'll show you the outlines of the cranial USG. It is difficult to complete all things in one session. So I'm trying to simplify as much as possible. What are the indications of cranial USG? So can you write in the chat box? What are the indications? I'll take just few seconds. What are the indications of cranial USG?
They have answered intraventricular hemorrhage, HIE, hydrocephalus, suspected DEET in preterm baby, intracranial hemorrhage in a neonate, and also terminal matrix hemorrhage.
So routinely, all the ventilated babies, we have to do USG brain to exclude the intracranial hemorrhage. Again, routinely, less than 32 weeks baby, as well as all the IUTR babies, less than 1.5 kg, we must do USG brain to exclude the IVH. Again, all the perinatal asphyxia and the seizure disorders patients, we must do the USG brain. And other indications are unexplained cardiac failure, congenital anomalies, this all. So which babies? This should be routinely all the ventilated babies, all babies less than 32 weeks or less than 1,500 grams. And if the babies are perinatal asphyxia babies or have any abnormal neurological signs. The transducer, I am using this, the 12S sector probe. You can use this this curvilinear probe that should be more than 7 to 15. This this is micro probe. If it is available, this is also good. And for the newborns, with 12 sector probe is also equally good. Bigger babies, which are they are having hair, so you can use the 6 sector probe. This is a bit the anatomy, cerebral hemisphere. We are seeing the interhemisphere fissures. This subsequently, this anatomy may help you to understand what is the corpus callosum part, because this part will be seen in the USG again. So here is the falx cerebri, here is the corpus callosum. These are the parts. Sylvian fissures, this is very important, which is this is developed after 28 weeks gestation. Again, the important landmarks, the basal ganglias. These are the thalamus, caudate nucleus, globus pallidus, and putamens. In general, it is difficult to differentiate all the parts. We can see the internal capsule and all the basal ganglia part together. So only and on when with the thalamus becomes hyperechoic, caudate nucleus becomes hyperechoic, and the other parts becomes hyperechoic, then you can differentiate all the parts clearly. So it becomes a pathological. This is an this is the when we'll see that this this temporal view or the axial view or the this mastoid view, we can see the ventricles in that way, ventricular systems. So this acoustic windows, this commonest area we are using the anterior fontanelle. This is the mostly we are seeing the anterior fontanelle, and the other parts are we can use we are using the this is called axial, this is temporal view. Another is the mastoid. This is the we are seeing the cerebellar view, and posterior fontanelle can supplement sometimes, but it is not always used. So these are the coronal views. Whatever we are using, we are, this is, if you think of this anterior fontanelle, this one. So anterior fontanelle, you will keep the probe fixed. You should not, and only you will, this indicator should be at the towards the right side. And here you if you give anteriorly or posteriorly, but it should be fixed, and just the swap, it is swapped in that way or swap in that way only. Even in sagittal view also, we are keeping this, the indicator, this should be at the frontal side, and you will swap laterally and medially in that way. So you must fix it, and gradually this way you will give. So these are the standard views: 6 coronal views, 5 sagittal views, 1 preauricular views. This is the axial. And 1 postauricular. This is called cerebellar. These are the standard views. So this is the, again, this is the anterior horn cell views. So we are keeping this indicator towards the right. Indicator, it is the towards the right side, and we are keep towards and the anterior fontanelli, and we are seeing this is the interhemispheric fissures, frontal lobe, and orbital ridge. So it is called the C1 image. C1 image. It was the orbital ridge. Then C2. This C1 image, you can understand this interhemisphere features, frontal lobe, and orbital ridge. This is the, you can see this. Another is the anterior horn cell views, C2. You go thus, first it was front. Gradually we are going to the, pushing the flow backwards. So here the anterior horn cell views. We are seeing this is the cavum septum pellucidum, interhemispheric fissures, and corpus callosum. And here lateral ventricles are seen. These are, and these are, if they become pathological, it will be seen large size. This is, you can see this frontal horn of lateral ventricle, cavum septum pellucidum, corpus callosum, interhemispheric fissures. This is the Sylvian fissures, the temporal lobe. These are now. This is the foramen of Monro view. We are giving the probe more posteriorly and in the middle. This foramen of Monro view, we are giving this anterior horn, and the third ventricle is visible here. Third ventricle is visible here. And this is the, most of the time, this view can identify most of the pathologies. And the size of the lateral ventricle, size of the third ventricle, these are measured in this view mostly. This is the plain body of the lateral ventricle. You can see the septum pellucidum, and this is the third ventricle. And here the thalamus. This is the corpus callosum is seen. This is the. Now, go further posteriorly. This is called the 3-dot view. Choroid plexus of all the lateral ventricle as well as the third ventricle is seen. That's why this is the 3-dot views. This is the 3-dot view. Body of the lateral ventricle, corpus callosum, and the third ventricle. And also, this side is the thalamus. This is go more posteriorly. We are seeing, if we go more posteriorly, we are seeing the occipital horn of choroid plexus. Body of the lateral ventricle, this is the anatomy. This is the most posterior view and in the coronal pitch. Most posteriorly, this is, we are seeing the occipital lobe. Here the occipital lobe. So this is the 6th zone. Angling even more results in an image that lies above the lateral ventricle. In this plane, the occipital cortex. Next is, now comes the sagittal view. This is the sagittal view, the pointing towards the anteriorly. Sagittal view, pointing towards anteriorly. This is the sagittal view. You can see This is the indicator is at anteriorly. Sagittal view. This is called lady in dress view. Standard sagittal view midline. We can see the third ventricle here. This is the lateral ventricle, cavum septum pellucidum, as well as it is the cerebrum. And this is the fourth ventricle also seen here. So this is the illustrated form. You can lady in dress view. Corpus callosum is seen here. Cavum septum pellucidum, third ventricle, aqueduct, fourth ventricle, pons. This part is the pons, and this is the cisterna magna, and this is the cerebellum. This is vermis of the cerebellum. So this is the anatomy. Mid sagittal plane. Okay, I think it's clear. Next is the right parasagittal. Now he will go to the right, towards the right side. We can see the chordothalamic group. So this part is thalamus, this part is caudate nucleus. So you can, it is generally, this group is divides the thalamus and caudate nucleus when they becomes pathologically echogenic. So this division becomes visible. This bleeding, generally, intracranial bleed first occurs at the chordothalamic group. This is the occipital horn and temporal horn also. So you can clearly see the frontal lobe, chordothalamic group, caudate nucleus, thalamus, as well as the choroid plexus. This is not bleed. Cerebellum and lateral ventricle. Second parasagittal view. So go more laterally. Here you are giving the Sylvian sulcus. So here Sylvian sulcus, insula. Then left parasagittal view, caudate nucleus, thalamus, occipital horn, temporal horn. Second left parasagittal view, Sylvian sulcus. And this is called the axial view. How axial view is done? This is done if you stress the along this anterior coronally, you go to the coronal sutures, coronal line, and go up to this area, temporal area, preauricular area. It is called axial area. Here, it is called also ventricular view. All the ventricles are visible in this view. These are the small lateral ventricles. When it becomes pathological, it is visible more. This is the third ventricle. This is the fourth ventricles. This is the aqueduct. So previous view, I'll clear. This is anteriorly. This is, we are giving the axial view. So this is cerebellar view. We are giving the mastoid. Here is the cerebellum. This is fourth ventricle and cerebellum. It's clearly visible here. Okay. So these are the three Doppler. So circle of Willis, we can see in all the views, but so Doppler, MCA and PCA will see at the axial view only. And whereas mid-sagittal area, like at the lady in dress view, we will see the ACA, anterocerebral artery. There are some normal variant, like is a cingulate gyrus without branches. So after 30 weeks, these branches appears. So if you don't get the Sylvian, this gyrus, that means baby is less than 30 weeks. Again, this is called choroid plexus cyst. This is the normal. Choroid plexus cyst or many patients, it normally can be present. So it is a normal variant. This is called again conatal cyst. This is also normal variant. So it is not abnormal, neither bleed, nothing. This is called cavum hargi. Actually, this is the extension of cavum septum pellucidum. This is the extension. Sometimes it is seen, not all the babies. This is extension of cavum septum pellucidum, and some views it is seen. And this is called cavum vergi. This is also normal variation. Now, I think everyone knows that IVH classifications. I don't want to go in details because the scope is, I don't have much time to explain. So I think grade 1, everyone knows, grade 2, grade 3, and grade 4 is not at all called as IVH now. This is a special view. It is periventricular venous hemorrhagic infarction. So this is the bilateral grade 1 hemorrhage. You can see coronal, right parasagittal, left parasagittal view. The most of the, you can see the chordothalamic group hemorrhage. This is the grade 1, grade 2. This is coronal section, right parasagittal, left parasagittal view. Grade 3, this is more than 50% with ventricular dilatation. Grade 3. So I'll show you one case. You will give in the chat box what is the diagnosis. This is the C1 view. So always we should go sequentially. We should not do haphazard way. So all the first, the coronal view, C1, gradually go to the C2, C3, C4, C5, C6, and then sagittal view, mid sagittal view, right parasagittal view, then the right parasagittal cortex view, then left parasagittal view, left parasagittal cortex view, and then axial view, and then cerebellar view. So always this sequence to be followed, and then we cannot miss anything. So this sequence, I'll show you. This is C2, this is C3, C4, C5, and this C6. This is the lady in dress view. Mid right parasagittal cortex view, left parasagittal cortex view, left parasagittal. This is the anterocerebellar artery. This is the axial view. Axial view, you can see the MCA artery. It is the PCA. And this is called the cerebellar view. So I think it is clear what is the diagnosis. Please write in the chat box. Please write in the chat box. I'm giving just 6-second time.
They have written IVH.
IVH.
But grading. What is the grade? It is IVH, it is clear cut. What is the grade?
Maximum answered for grade 2.
What is grade 2? It is 10. There is ventricular. You are seeing here there is ventricular dilatation is there. So if there is ventricular dilatation, it is grade 3. Okay. There is ventricular dilatations there. Again, bleeding the chordothalamic. You can see the chordothalamic groove, grade 1. This is this kind of bleeding more than 50%, grade 3. Another is the intracranial hemorrhage. So we can see these are the, sometimes may not be the this intraventricular hemorrhage. You can see the intracerebral hemorrhage. This is the intracranial hemorrhage. Sometimes we can get the cerebellar hemorrhage also. This is the case of hydrocephalus. You can see the C3. This is posterior fossa cyst causing hydrocephalus. So hydrocephalus, we are measuring in that way. First, you will see the ventricular index. We'll give the ratio, and we'll give the anterior hornsel wide, and we'll give the third ventricle size as well as the fourth ventricle wide. So in that way, there are some action lines are there when to do interventions. We don't have the scope to discuss in details. So, but these measurements are very important. When to start intervention. This is the Leibniz index is called, or ventricular wide. This is the anterior hornsel wide. Left ventricular ratio, third ventricle wide. This is the thalamocortical index. This is the another things we'll measure. This is the third ventricle wide. Third ventricle wide. We can see in the C3 view as well as the, this is preauricular or the axis. Fourth ventricle measurement we are seeing at the cerebellar view, postauricular. So in that way, there are the, we'll measure it, and there are charts are available. And in that chart, we'll plot and chart, and in that way, we'll determine what is the action line for that. And in that way, we're planning for that, how to manage. Various features of HI. Like HI, you can see the gross cerebral edema, ventricles are chinked, and sometimes there's the hyperechogenicity of the thalamus and the caudate nucleus. So when hyperechogenicity is seen, so you can see the posterior limb of internal capsule between thalamus and caudate nucleus. This is the single term asphyxia baby, HI3 required cooling. You can see this is the thalamus, is the hyperechoic here. Here, thalamus and caudate nucleus, this is called the four column sign. This is the classical of this HI. You can see the hyperechoic view of the thalamus and caudate nucleus, and between the we can see the posterior limb of internal capsule. This is the huge hyperechogenicity due to the HI. Here also you can see this hyperechogenicity, the thalamus, and you can see that you can divide the thalamus and caudate nucleus. This is the hyperechogenicity in all the views. In HI, you will get initially you will get the less RI index. So I will not go in details of Doppler. I think this is the another view of HI. Here is a cerebral edema. So due to that, you cannot differentiate any ventricles. Hardly you are seeing any ventricles. Gross cerebral edema, ventricles are not seen. And gray white matter also not differentiated here. So here again, Can you diagnose this case? Please write in the chat box. This is the congenital anomaly. Can you diagnose the case? Have you written?
Yet no answer is there.
So you are seeing the parallel ventricles. Parallel ventricles. This is a classic of that corpus callosum agenesis. It's the parallel ventricles. This is a game. So, can you diagnose this case? Can you diagnose this case? At the C5 view, I'm seeing something. Write in the chat box. Huh?
Answer for Dandy Walker and also for Chiari malformation.
Nah, it is Gantrover. This is the, you see the cyst at the posterior fossa. So, okay. So this is the Dandy Walker variant. See the cyst. This is the vermis, comes this area, cerebellar. Cerebellar area, there is a cyst. Now, they are the PVL. So PVL, you can see the hyperechogenicity initially for 7 days. And now comes the cyst, gradually appears cystic dilatation all over the cyst. PVL, you can see the PVL 1, 2, 3, 4. I will not go in details of the definitions. This is the picturization. So this is kind of PVL. This is, you see the PVL. This is the, just few days ago, we saw this patient. There are extensive this cystic lesions. This is a grade 4 PVL. Next comes the infection. Again, the infection, this is the generally, if this kind of strands, or sometimes you can see this, there are some particles or debris visible sometimes. This debris are also sometimes visible. So this is a kind of bacterial infection. Generally in the bacterial infection, this pus and strands, if you see, this is a, and there is a thick pus. When we do the lumbar puncture, due to there is thick pus was coming. This is the infection due to the, this is the bacterial infection. This is a ventriculitis. Another is that these are the fungal balls. These are fungal balls. Okay. So I think I kept in these slides only. So I didn't extend much. It is short time. So any questions anyone can ask?
Actually, there is a question that how to differentiate between bleed and choroid plexus.
Bleed and choroid plexus. You see the normal, first you see this normal. This is a normal view. This is the choroid plexus. This is a normal choroid plexus. You see the normal views. This is the normal views. But you see, this is the thalamocortical, this area. So I'll show you the normal first. Choroid plexus are visible here in the these C4 views. Choroid plexus are visible. as well as the parasagittal view. This is the choroid plexus. This is the choroid plexus. And this group, this is the chordothalamic group. The bleed occurs at the chordothalamic groups. This is the normal sides. If you see this normal side, this kind of choroid plexus, this is unlikely to be bleeding comes here. If the bleeding comes here, bleeding will be in that side. This is, again, you can see this normal choroid plexus. This is the normal sides. You will not see this kind of other side, other views. Again, you can see another choroid plexus are seen at the third. 3 dot. Here also choroid plexus are visible. So this is the C4 view. Another is the parasagittal view. You can see the normal choroid plexus. This is the normal choroid plexus. If you both are hyperechogenicity, so it sometimes you may confuse, but these are the normal sides of choroid plexus. Bleeding occurs first. Bleeding occurs. These are germinal matrix area, and here you can see the chordothalamic group bleeding. You can see chordothalamic groups, and other areas also bleeding can occur. But this is the normal sides of choroid plexus. So I think visualization that these places you should keep in the eyes. Other places you will not see choroid plexus. Any other? Any other questions?
No more question till now.
I think I have completed before time.
Thank you, sir. I think in all our setup, US estimation is available now, and I think all of our residents are to some extent familiar with USG brain.
Yes.
So,
Most of the cases I have taken, actually, I was there in the BC Postgraduate Institute. Most of the cases taken from the BC Postgraduate Institute only.
Okay, sir. Shogata sir had enriched us with his excellent and lucid presentation, how to approach to newborn brain, its indications, procedures and science behind that, its anatomy and various pathologies. So thank you, Shogata sir, for your lucid presentation. And this is the last session of our symposium. For conclusion, I like to hand over mic to Mihir sir and Sapun sir.
Mihir first. I think Mihir is not there. So I am thankful to all the faculties who were present for the last 3 days, and most of them have done justice to the requirement of the attendees. And West Bengal Academy of Pediatrics will do further this type of symposium in future under the leadership of Dr. Mihir Sarkar, Professor Kalpana Datta, and Dr. Dibyendu Rai Chaudhary. So if you have got any suggestions, you can put it in our WhatsApp group. And if you have got any criticism also, that what is your expectation if you could not fulfill that, that also you can write it down, because constructive criticism always helps to provide better service in the future also. So thank you very much. I'm really thankful to today's coordinator, Dr. Pradeep Paria, and I'm thankful to Arundhati and Dr. Mihir Sarkar also, and hope to see you soon in the next symposium. And Shogato, it was a splendid experience for me to listen to you in this symposium. But I would just request one thing: if you just allow me to go in the SSK hospital to take that training, and this is a 7 days training, if you can do the hand-on training on that, that will be much more helpful for all of us. In fact, I can be your student also.
Yeah, I think it is possible only. And USG brain is most, because USG brain, I think it is very easy. But there are some, this is a structured method. And if, because ultrasound machine is available, all the NICUs nowadays, in the government hospital, private hospitals. So the basic lines, if we, because this is the, if it is must now, the point of care, this ultrasound is must for us. So this is, I think, it is easy also. We can organize some.
Hand-on experience
Yes.
would be much more helpful. A 7 days course or 1 month course or something like that, that would be helpful. So Mihir, please conclude the day. I think he is not there. Yeah, he is there. He is in chamber. Please conclude the day.
Yes, okay. Thank you, Swapan-da. Thank you, Saugata-da, for excellent presentations and very interactive session today. And we hope the recorded video, will send the recorded video in the group, delegates group. We will get again, you can see several times, because it is dependent on the pictures, and again, you need some references during your day-to-day practice, then we'll able to see that. So we'll share the videos very soon, and you and again, thank you all the team of West Bengal IIT. Our president, madam, and other members are not able to join today, but Dr. Swapan Roy, our scientific chairperson, and Dr. Pradeep Paria is there, who has coordinated the whole, and Dr. Urundhuti Banerjee, who has coordinated the whole program, and also the talk to the national faculties and invited them, and also the team with technical team, Somnath, for your technical support. Without any technical glitches, it went on smoothly. For the thank you, and thanks all the delegates who have participated and interacted. We'll again, I hope to meet with the next program in the next month. We'll let you know, and in the group, so what program we'll come up with. You can suggest in the group what you want to do. Otherwise, we have planned to do with the EEG and the other and the NCV and EMG in the next session. So it will be another interactive session. Until then, we will again thank you all and conclude the session.
Thank you. Good night.
Thank you. Good night.
Maybe during my presentation, I got that bad news.